We're delighted next to have Josbert Keller, and I think his presence here, we're very lucky, and it certainly is indicative of this field moving from ideas to practice, in that, his group published this paper in the New England Journal recently that involved fecal transplants for treatment of Clostridium difficile colitis. And Josbert is from Amsterdam, where he trained at the Academic Medical Center, where he's currently in the Department of Gastroenterology, and at the Teaching Hospital. He tried to help me pronounce that properly. Yeah, I was close. And I do know it's Den Haag in the Netherlands, and he's also been the secretary of the Netherlands Society of Gastroenterology. I asked him to approach this talk with the speed of a colonoscopy as a gastroenterologist. But it is amazing to consider how we're unfolding all this basic knowledge, but here is an application which really appears virtually ready for prime time in clinical medicine. I also wanted to mention, because a couple of people have asked me questions, that the National Institute of Allergy and Infectious Disease and the FDA are jointly hosting a workshop on this topic, a public meeting May 2nd and 3rd at NIH Lister Hill, on the use of fecal transplantation in therapies, and to look at some of the scientific and other issues around that. So anyhow, go right ahead, Dr. Keller. Thank you.
Thank you. Thank you for the opportunity to join this wonderful meeting. The topic I have to talk about, that is particularly attracting journalists who are sometimes writing very serious stories about it, but sometimes making jokes of it. That's no problem, of course, but for the patients who have recurrent Clostridium difficile infection, it's no joke at all, because donor feces infusion may be the only way we can cure them. This was such a patient who was admitted with a cerebrovascular accident and treated with antibiotics for recurrent urinary tract infection during the admission, and developed a Clostridium difficile infection that was first treated with metronidazole, then with metronidazole and metronidazole, followed by a tapered and pulse schedule. And the idea behind it is that you can let the spores, which are antibiotic resistant, grow out, and those germinating spores can then be subsequently be killed by the vancomycin. However, it didn't work, and it doesn't work in most patients. I don't think we should use that weeks-lasting schedule anymore. So she was treated with vancomycin and metronidazole. It didn't work. We went on. And then there was the fourth recurrence, so the fifth episode already. She was hospitalized for more than 3 months. She couldn't go to a revalidation home. During this hospitalization, there were very costly isolation precautions necessary. So how should we go on? Yes, you can guess that she was treated with donor feces transplantation. At that time, her son was the donor. After treating her with a few days of vancomycin, so we always say 4 to 5 days, but probably 3 days or a week, that's all okay. Or you could also start fecal transplantation after 3 weeks of vancomycin, but maybe there's no need, so you will not do that. Then, after 4 days of vancomycin, she was treated with bowel lavage using a microbiota solution, which is similar to what is used for bowel preparation before colonoscopy. And on day 5, there was infusion of about 500 cc solution made of 0.9% saline and 150, more or less 150 gram fresh donor feces. Here you can see how easy it is to make that. So those were initially refused by a Dutch medical journal. Sometimes I use them for presentations. These are the feces, of course. You put some saline in it, you just mix it, you filter it through a gauze, and then this is the solution. It's like chocolate milk, a little more green, and you can infuse that in the patient. There are several ways to do that. This patient has a nasal duodenal tube, well, she's not aware even that it is infused. Here, the patient is also not aware, but this is more painful and less well tolerated, and for logistic reasons, less easy. This is done by colonoscopy, and the patient was cured. Now, let me see. Yes. So, Clostridium difficile is a gram-positive spore-forming bacterium that accounts for about 10 to 25% of the episodes of antibiotic-associated diarrhea. In 1978, it was recognized as the cause of pseudomembranous colitis, which is caused by a direct effect of the toxins on the colonic epithelium and also by attraction of the inflammatory cells by the toxins. Already since the 90s, there is a gradual increase of the incidence of Clostridium difficile infection. These are the hospitalizations complicated by C. diff, but it lasted until 2005 that there was very serious attention for it because of those outbreaks with the hypervirulent ribotype O27 strain that caused more severe phenotype, more recurrences, and more deaths. It was an outbreak that was at the same time in North America and also in Western Europe countries. Clostridium difficile can only occur in a bowel with a disturbed intestinal flora, and that typically occurs after antibiotic treatment. And if there are of course other causes, but that is more or less rare. Almost always you need antibiotics before you can become susceptible to Clostridium difficile infection. And if there's a disturbed flora, you can acquire more easily C. diff. So that's for some people that's not easy. That's difficult because in the general population there's a colonization rate of about 2%. But if you are hospitalized, then the chance of getting colonized by Clostridium difficile increases with a longer stay. So after 2 weeks, the colonization rate is about 13%. So if Clostridium difficile can grow out in your colon, you still can be lucky and be asymptomatic if you have probably it's related to an appropriate immune response against the toxins. Otherwise, you'll get diarrhea, pseudomembranous colitis, or some cases fulminant colitis, which can be deadly disease. So from this scheme, you can see how you can prevent Clostridium difficile infection. First of all, I think restrictive antibiotic use, that's the most important. Second of all, you just need normal hospital hygiene and isolation precautions. And finally, people hope that probiotics can prevent Clostridium difficile infection if it is given together with antibiotics. There are now more meta-analysis and reviews about the topic than true studies. All the studies have major limitations and show at the best a very moderate effect. But if you pull all those data, you can show a relative risk of about 0.34. But I think that we should be very carefully in believing that this is a true effect, and I think further studies are needed to show that there is a role for probiotics in the prevention of Clostridium difficile infection. Yes, there we go. So the treatment of Clostridium difficile infection is almost always with antibiotics, although it is in most cases a self-limiting disorder that will and it will suffice to stop the offending antibiotic. There is one trial, only one placebo-controlled trial, showing an advantage of vancomycin compared to placebo. That was from 1978, and it showed that you had less diarrhea in 5 days. So that's the evidence. But I think everybody agrees that you should treat Clostridium difficile, if only to protect the other patients in the hospital, for example. So the problem of treatment of Clostridium difficile is that if you treat an initial episode, there's a chance of recurrence of 15 to 30% within 10 weeks. But most of those recurrences occur within 14 days, and that happens more often in older patients with older age. So the patient I presented, she was older. She had comorbidity. She stayed in the hospital longer, and also a problem is if you need repeated courses of antibiotics, that also predisposes, of course, to recurrent Clostridium difficile infection. And but I talked about that already. The hypervirulent O27 strain. And recurrent Clostridium difficile is caused by prolonged loss of the normal homeostasis of the flora, which is characterized by, amongst others, loss of bacteriology species and loss of diversity. It can be caused by the same strain that caused the initial episode, and there it reflects that vancomycin or antibiotics cannot kill the spores, and the spores will grow out and cause again Clostridium difficile infection, but it can also be caused by another strain. And then it reflects the fact that a prolonged disturbed bowel flora makes patients susceptible in acquiring novel Clostridium in general. So furthermore, the absence of an immune response may be related to recurrence, and I've talked about that already twice. If you have a recurrent Clostridium difficile infection, then the guideline says, well, you treat it with the same antibiotic as the first episode. That's metronidazole, but the response rate is only 55%. Vancomycin has a similar very low response rate. There's a new antibiotic, fidaxomicin, which is very expensive and which may have a little higher response rate, or maybe you shouldn't say response rate, but long-standing response, because most patients will respond, but there will come recurrence in all those, in 45% and 25% of the patients with fidaxomicin. So fidaxomicin might be a little bit more effective, but further studies are needed to show that indeed. If you have a second response, the success rate further drops, and in fact, it is very disappointing to treat those patients, and there's no evidence for this tapered pulse regimen which lasts for weeks. So that is the reason that we continue with donor feces infusion, and that donor feces infusion, well, what's happening there? That donor feces infusion now got this true place in the treatment of those patients. The first report about it was already from 1958. Well, there are some Chinese reports of centuries ago, but the first real report was from a U.S. surgeon, Dr. Eisenman, who treated 4 patients with pseudomembranous colitis on an ICU unit with enemas and cured them all. Since then, more than 40 patients have been reported in the literature. There are many different routes. So we initially used colonoscopy. I think nasodiluvial tube is better tolerated and easier for logistic reasons, and it works certainly as well as colonoscopy. Although there is a review which suggests that colonoscopy or enemas are better. You can use enemas also. That is maybe the most easy way to do it. I think that we need a study to show non-inferiority with the nasodiluvial route. And I believe that there are also people who try or doing it already with capsules, and in fact that works as well, they told me. So there are different protocols for the pre-treatment. You can use vancomycin. Should you use vancomycin? I don't know. But in daily practice, you will always start vancomycin if a patient comes to you with a recurrence, and then arrange the donor feces infusion, which takes a few days. So there's no problem taking vancomycin first, and probably it also helps to reduce the burden of Clostridium difficile in the bowel, and there might be even a difference between fulminant CDI or Clostridium difficile diarrhea, or getting patients first in remission, so they have a more or less normal bowel pattern, stool bowel pattern, and then treat the donor feces. I think bowel lavage is not required, but many people will do that. and the amount of feces in the literature differs between 5 to 200 grams. I think that there is more or less a cutoff at 50 grams because reports of patients treated with less than 50 grams show more failures. But that has to be, we don't know what if there was something wrong with the donors or something. Maybe if you can identify a very effective donor, you can suffice with 10 grams. But what is consistent in all those reported patients is that there are a very high success rate of about 90%. In Amsterdam, a few years ago, we started treating some of those patients, and then we decided, well, we need to show that it indeed works, and we cannot continue just treating all the patients without evidence. And we started a fecal trial in which patients with recurrent CDI after at least one course of adequate antibiotic therapy, so also patients with the first recurrence could be included, were randomized to either vancomycin, that was the standard arm, vancomycin for 4 days or 5 days, followed by bowel lavage using a microhole solution, and then donor feces infusion. That was the experimental arm, and we added a second control arm because clean prep or microhole solution was included in this treatment strategy. So we wanted also to control for that. We plan to include 120 patients, and the patients were followed for 10 weeks. Patients were excluded if they needed antibiotics for other conditions, if there was prolonged compromised immunity, or if they were severely ill, and that was because of the results of the Dutch ProPatria study, in which probiotics were given to patients with severe pancreatitis, and we saw that those patients randomized to probiotics had a higher chance to die. The donors were initially screened by a questionnaire that is also used for donation of blood. Subsequently, the feces and the blood was screened for potential transmissible diseases, and you can even extend this list if you want. But we use those tests. And the day before infusion, there was another checklist addressing the last 2 or 3 months, asking if there was a recent illness, different sexual context, traveling, or recent antibiotics. We never saw a problem with transmission of an infectious disease from a donor to a patient, but I think it is important to be very carefully with that always. And many people now want to try donor feces infusion for many conditions. I think we should be very careful with that. So 120 patients were planned, but the study had to be stopped early after inclusion of 43 patients, and the reason was that in our power calculation we assumed that donor feces would be effective in 90% of cases. That turned out to be more or less true, but we expected a cure rate of vancomycin of 55%, and that was based on literature reports of a first recurrence. But in our included patients, the median number of recurrences was 3, ranging from 1, that was a handful of patients, to 9. And the expected cure rate would be much lower than 55%, probably below 30%, and that was also the case in our patients. The control group had very disappointing outcomes. In the patients treated with vancomycin and bowel lavage, 23%, and in the vancomycin group, 31%. And that was the reason that the study had to be stopped. And I also think that, in retrospect, that it was a little optimistic and naive to think that patients with the first recurrence were ready to undergo donor feces infusion as therapy, because they still had, although not very huge chance, but they had the possibility to be cured by antibiotics of about 55%. And these are the results. Again, after one infusion, 81% of patients were cured. After 2 infusions, 15 or 16 or 16 or 17 patients were cured, because we had to take out one of the patients after comments of the reviewers. And in the vancomycin and bowel lavage group, there were very disappointing results. We didn't encounter many side effects. In fact, only diarrhea was reported at the day of the infusion of donor feces, and that was that lasted like a few hours. And later on, patients were complaining of constipation. In fact, the patient is cured the day after donor feces are infused. We looked also with the HIT-chip at the microbiota of donors, patients before and patients after donor feces infusion. And what you can see is that the diversity after infusion is similar to that of the donors and before donor feces infusion. So in the recurrent C. diff state, the diversity is very low. That is associated with also changes in bacteria. In recurrent C. diff, there is an absence of bacteria, a relative absence of Bacteroides, and they increase after donor feces infusion. And at the same time, you see that there is a decrease of some members of the proteobacteria that are some potentially opportunistic bacteria. They decrease after donor feces infusion, and they are increased in patients with recurrent C. diff. So the conclusion is that C. diff, Clostridium difficile infection, is an infectious disease of a bowel with a disturbed flora, and that antibiotics in the recurrent state are ineffective. It is also a model to study the normal and the disturbed microbiome, because you have an easy and true clinical endpoint. And donor feces infusion has a high cure rate in those patients. In fact, I believe that if you cannot cure a patient with recurrent Clostridium difficile infection by donor feces infection, you should do the workup for chronic diarrhea again. So you should do repeat colonoscopy, exclude celiac disease, and all those things. It is a safe and well-tolerated treatment. Of course, it's unappealing, and I certainly hope that in 10 years we will have an alternative for it. And we have shown, but also others have already shown, that it restores the healthy microbiome. Further research should, I think, focus on the prevention of C. diff, and we really need a powerful probiotic for hospitalized patients that have to be treated with probiotics. And further research should focus on a powerful probiotic mixture that can replace donor feces infusion. So others have already done that. There was a case report, 2 patients, case series even, patients with multiple relapses, and they were treated with a mixture of 33 filtered bacteria from one donor. It was infused by colonoscope. Both patients were cured. Someone told me that the third patient was no success, and we just have to see what will come out of this. And also, already in 1998, Dr. Tvere from Denmark has cured some patients with a mixture of bacteria. So there are other potential applications of donor feces infusion. There were already several talks about IBD. I think the claims that it works in IBD all come from one group in Australia, and others could not reproduce the high success rate. So I think this is still very experimental, although many patients ask for it and mail me, please, can you give donor feces transplant for ulcerative colitis? So I think only in experimental studies and not normal patient care. There are even more obscure indications. It's claimed that it can help for multiple sclerosis, constipation. I don't think that's something to talk about yet, and maybe not for the forthcoming years. But obesity and insulin resistance is also something we talked about it before. Already in 1954, there was a well-controlled trial in Navy recruits who were treated with prophylactic antibiotics, I think in the flu season or something, or placebo, and it was noticed that the persons who were treated with antibiotics had a gain of weight compared to the placebo group. It was a very nice study, in fact, and Also, there were the observations that were already discussed, that there is a disturbed microbiome in obesity, and the publication of the group of Gordon, in which germ-free mice were colonized by like kind of lean microbiota or obese microbiota, and if they got the microbiota of obese mice, their gain in weight was more pronounced. So those observations led to the initiation of the Fat Boost trial at the Academic Medical Center by Max Mueldorf, and that was also the one who came up with the term Fecal trial. I think he learned it from the cardiologist, and he included 18 patients with a BMI above 30 and insulin resistant without anti-diabetic therapy. He did before randomization in hyperinsulinic clamp, that is an advanced way to measure insulin resistance, and he sampled the patient and the feces, he took samples of the small intestine and feces. Patients were randomized then for bowel lavage, followed by allogenic transplant by the feces from a lean donor, or autologous transplant. And subsequently, he repeated all those tests, and then, of course, it didn't do anything on true clinical parameters, but he showed that after allogenic infusion of, let's say, lean donor feces, the insulin sensitivity increased after increasing those patients, and it did not, and it didn't change after autologous transplantation. So, furthermore, he also showed some changes in the composition of the flora. He showed an increased diversity after transplantation, and he showed also a change of many different bacteria, amongst others, to butyrate producers. I think that these studies are just proving the principle that you can do something, you can alter something on insulin resistance and the metabolic syndrome by donor feces infusion, but it's very experimental, and patients are really willing to undergo those treatments because, well, it's better than a diet. But for most, but I think that's a lot of work has still to be done here. This is the slide with all the people who worked on these studies. Thank you for your attention.
Thank you so much, Dr. Keller. We have time for some questions, particularly because Dr. Keller has to go. I wanted to ask one, which is, what about patients with very far advanced colitis, like toxic megacolon? Have you tried this in patients, with very severe colitis as therapy?
No, we didn't do it, and we didn't do it also we excluded them in the trial, but there are reports that it works as well. So I think if you have a very severe colitis, you should proceed to surgery, and if there's a reason not to do that, or if you have time, you could try it. Yes.
Thank you. Okay, there's a bunch of questions. George and David.
Thank you for the entertainment. I enjoyed it enormously. The numbers are still small but impressive, and so the definition of cure is valid at this stage. Are you enrolling these patients in a more extended longitudinal study in terms of a future antibiotic encounter as to whether or not they will recolonize quickly with C. diff?
You mean if we follow them for a longer period?
Yeah.
Yes, we did. There were no. I think we followed them for more than a year, most of them, and there were no recurrences anymore. Also, not after subsequent courses of antibiotics for urinary tract infection or airway infection. No, we didn't see any recurrence, and that's also not reported in the literature that patients. There's not kind of a genotype of a patient who will keep on going with those recurrences. After it's treated, you're done with it for for a long time.
David?
Well, so that was in part my question. I've spoken to some of the other people in the States who have done large series, and they too see very high cure or response rates. But their observations, unpublished as you say, is that in their experience, some of their patients who seemingly are doing well, when given even a sniff of an antibiotic 6 months later, now stumble right back into a disease-associated state. In other words, that the recovery is fragile, the ecosystem is not as robust as it might be in other circumstances. But this is just a sense they have, and I'm very,
Well, there might be patients that recur. We didn't notice it. For example, I discussed this with Tom Louis from Canada, and he also says most patients can easily be given antibiotics without having I think after 10 weeks, you should call it also an awful episode of Clostridium. You cannot really keep on calling it a recurrence, but although maybe the same strain could grow out in someone who is colonized, but it may occur, but it's not the usual pattern. No.
Dr. Mills.
Yeah, I just had a question. How do you decide, other than the normal exclusion criteria that you had for the donor, how do you know who's a good donor? And I mean, is there a better donor than other donors? I've talked to clinicians who've done some of this in Minnesota, and I asked him, well, where do you get your poop? He said, we got this 25-year-old in the lab, and he provides all the poop. I couldn't figure out how you, is there a super poop out there?
I assume there will be, but we don't know. And all our donors had also failures. So we did not have the perfect donor of them, but we had some donors who donated only twice, one successful, one failure. We had also donors who donated 8 times, one failure. I would like to have that donor.
The same that there's the proposed enterotypes. Are we going to start typing so that you might have targeted poops to your host genetics or something like that?
No, but we have to look at that again because we have too few. We had in the study we had too few donors to really draw conclusions of it. But we have to look at the samples again now with a larger group of donors that we have used after the study was stopped, and then try to find out who is the best donor. Yes, and then he cannot change the relation. He cannot travel anymore. Yes, he has a problem. Okay.
It should certainly be possible to do this with bacteria, unless there's some magic ingredient here.
Yes.
Yes.
So you mentioned IBD, and I know people are trying this. Is your view that has been tried carefully and convincingly and didn't work? Or is your view that it hasn't been tried in a manner that you or others would find acceptable as proof or disproof that it would work?
Well, it's certainly not proven that it's effective. There's only one group who claims that. There was a study in Leuven from Sabrine Vermeer, and that was terminated because it didn't work. But I think that if one study doesn't show any efficacy, well, I did also some patients, and it didn't work as well. If one study is stopped, it doesn't say that. It doesn't mean that you cannot go on studying it. I think that the protocol can be changed. Maybe the protocol was wrong. Maybe you need weekly. Maybe you need higher amounts. I think that's something we have to study because I do not believe that there is no effect in altering I cannot imagine that there's no effect at all if you try to alter the microbiota of those patients. It's a very attractive and good hypothesis that is also one of the possibilities to treat those patients in the future. So far it's disappointing, but maybe it deserves further study.
We talked a lot about the kinetics of these things. How long have you followed the recipients to see whether they maintain the microbiome structure by 16S of the donor?
No, not that long. I think we have a follow-up for the 3 weeks and at 8 weeks or something. But then then we didn't follow that anymore. But over a period of like 2 months, I think it was 2 months or something, it stayed stable.
Thank you.
In very few patients.
A related question to that, did you look at more sensitive methods, like PCR for C. diff, and to see eradication and quantities in the two treatment groups? I'm sort of wondering, does the combination of new flora and antibiotics eradicate C. diff?
No, we did not. We tested it with the ELISA test, which is not suited for that. So we did not. I think we have, not in the study, but we have one patient that was treated before the study was initiated who became a carrier, who became colonized with it. But I don't think that's a test that you should use to follow up C. diff. So we did not do that. I don't have results of that.
Thank you. Any other questions? Well, thank you so much for coming all the way here and telling us about this.
Thank you for the opportunity.
And we have a break now.